This talk is an overview of medication-assisted treatments for substance use disorders. Medication-assisted treatment, or MAT, is the standard terminology for the use of medications to treat substance use disorders, which are used in combination with psychological and social interventions. I'll provide a simple outline of the major categories of substance use disorders and their first-line treatments. I'll separate the disorders according to those which have FDA-approved treatments and those which do not. Alcohol, nicotine, tobacco, and opioid use disorders all have FDA-approved MAT. Cannabis, stimulant, benzodiazepine, and hallucinogen use disorders do not, though there are still some guidelines on how to treat them. Now, let's walk through each substance use disorder and their MAT. For alcohol use disorder, first-line treatments include naltrexone, an opioid antagonist, and acamprosate, a glutamate modulator. There are also second-line treatments including disulfiram, topiramate, and gabapentin. For nicotine and tobacco, there are 3 treatments considered first-line: varenicline, a nicotine agonist; dual nicotine replacement, for example a nicotine patch plus a nicotine gum or lozenge; and the atypical antidepressant bupropion. Here, I place varenicline first because there is some evidence that it is associated with higher cessation rates than the other 2. Opioids are a bit trickier. The preferred treatment depends on whether the patient has completed opioid withdrawal or not. Opioid withdrawal is not life-threatening, but it is extremely uncomfortable, including symptoms such as nausea, diarrhea, muscle aches, sweating, and insomnia. This uncomfortable withdrawal is a large contributor to relapse. If a patient has completed withdrawal, the first-line treatment is the same as for alcohol, the opioid antagonist naltrexone. But if a patient has not completed withdrawal, then to avoid withdrawal and the potential for relapse, an opioid agonist strategy is required. The first-line treatment is buprenorphine plus naloxone, an opioid agonist plus an opioid antagonist, the combination of which limits the potential for overdose. Second line is methadone, a pure opioid agonist. You can use these tables as a reference, but at first, I would recommend only memorizing the first-line treatments highlighted here. Finally, let's briefly review the other substance use disorders without FDA-approved MAT. For cannabis, some treatments under study include N-acetylcysteine, or NAC, gabapentin, and cannabidiol. For stimulants, the first-line treatment is contingency management, in combination with other psychosocial interventions. Contingency management involves using incentives to encourage treatment adherence and substance abstinence. Some medication treatments under study include topiramate, long-acting amphetamines, and bupropion. For benzodiazepines, although there is no MAT shown to promote abstinence, guidelines for management include first tapering off of benzos with a long-acting benzo, such as diazepam, then preventing recurrence by avoiding benzos and providing psychosocial support. Finally, I am not aware of any recommendations for management of hallucinogen use disorder, other than general psychosocial interventions. That's the end of this talk. Substance use disorders can be exceptionally difficult to treat, and there is much more to be said about the psychosocial interventions. I hope this talk serves as a basic organizer for the different pharmacologic treatments available. Thank you.